Hello, friends. So today I'll be just talking very briefly on the snippets on abdomen compartment syndrome. So it's just a brief snippets. I was part of one of the panel that happened on 8th February with Professor Manu Malbrain. So for most of the listeners, you would know that he was the main man who's done a lot of work on abdominal compartment syndrome. So we had an excellent panel with esteemed panelists like Supradeep Ghosh, Parveen Kaur. And we did discuss about only certain specific aspects in abdominal compartment syndrome. So there is a separate video on abdominal compartment syndrome. I'm sure many of you may have watched. You can go and watch. So this is to just cover certain specific issues in abdominal compartment syndrome. So the first issue which I had to address was, what do we understand by acute GI injury or acute gastrointestinal injury? So for all the trainings, it's important. So this is a word not necessarily we may have heard in our formative years. So this is a possibly a relatively newer nomenclature. So what is the definition of acute gastrointestinal injury, AGI? So the definition is where there is a gastrointestinal dysfunction as a part of multi-organ dysfunction. So we understand when we say multi-organ dysfunction in ICU, we talk about respiratory dysfunction, cardiovascular dysfunction, liver dysfunction, renal dysfunction. So seldom do we talk about GI dysfunction. So GI dysfunction that sets in as a part of multi-organ, not necessarily due to primary GI pathology. So it may not necessarily, it's like an ARDS where it's an inflammation of the lung that happens due to either pneumonia or due to extrapulmonary cause. It's something like that, where GI dysfunction sets in as part of multi-organ due to primary abdominal pathology or as a secondary sort of a sequelae. So, and the studies have shown that secondary acute GI dysfunction or acute gastrointestinal injury, which means the source is somewhere else and GI dysfunction has set in, the mortality is 71 times higher. So the odds ratio is 4. So it has a direct bearing. So GI dysfunction has a direct bearing on the outcome. And this was the study where they have shown with each additional year when there is a GI dysfunction sets in, there is fourfold increase in mortality. This is terribly important for all the listeners in ICU because very often you would see the elderly patients that we deal with often tend to have GI dysfunction. When I say GI dysfunction, it could be as simple as someone not opening the bowels and being constipated in ICU for 2 to 3 days. So all this constitutes GI dysfunction, and we see this in our elderly population or intestinal obstruction. All this has a direct. So when you counsel the family, GI dysfunction is not a benign thing. So when there is a GI dysfunction, it has a direct bearing on increased mortality up to fourfold. So that is the sort of magnitude or impact it has. And in patients who are ventilated and who have GI dysfunction, the mortality is 63-fold. So it is like a mammoth increase in the mortality. And for every additional day in ICU with GI dysfunction, so the mortality increases by zero 0.9. So these are some of the statistics that have come from this study. So the essence is GI dysfunction, any GI dysfunction cannot be ignored. It has a bearing on the outcome. So that's the whole science. And there are four grades of severity of acute gastrointestinal injury. So the grade one is defined as self-limiting, where GI dysfunction, you don't need any interventions to set right. It's a self-limiting, but it portends future risk of GI dysfunction. So the grade one is any absent bowel sounds or constipation for 1 or 2 days, which is self-limiting. You don't need anything and they get better. Or post-operative absent bowel sounds. All these belong to grade one acute GI dysfunction. Grade 2 is where some intervention is needed to restore GI function, like someone may need laxatives or enema to clear the bowels. So as you see, grade 1 intra-abdominal hypertension is grade 2 acute GI, or constipation for 3 days, where you may have to give laxatives or enema is a GI dysfunction or feed intolerance. Grade 3 is where there is GI failure, progressive intra-abdominal hypertension, or stress ulcers. So these are some of the examples of grade 3 where there is GI dysfunction, where feed intolerance is there and you cannot continue the feeding for whatever reason. So that constitutes grade 3. Grade 4 is where it is life threatening. GI dysfunction having a direct impact on life threatening, like as a part of multi-organ dysfunction or abdominal compartment syndrome. By now, most listeners would know abdominal compartment syndrome is where there is sustained increase in intra-abdominal pressure with organ dysfunction. It could be acute kidney injury or respiratory failure or hemodynamic instability and so on and so forth. So these are the grades of acute GI injury. So the second issue that we had to address was just a brief overview on ACS. So when we say abdominal compartment, ACS is not coronary, here it is abdominal compartment syndrome. When there is sustained increase in the IAP, more than 20 millimeter with organ injury. So this organ injury can be any of the organ injury. So the earliest organ to get affected in a compartment would be acute kidney injury. And this is followed by GI dysfunction, followed by respiratory dysfunction, followed by cardiovascular dysfunction. So the last one would be hemodynamic. I'll show you a graph for that. 25% of the mixed ICU patients are at a risk of developing intra-abdominal hypertension, which can eventually lead to abdominal compartment. So these are the statistics about the mortality correlation with intra-abdominal hypertension. As you see, grade 1, 20 to 30% constitutes grade 1 and mortality is 10 to 25. So when it goes to a compartment, the mortality sits as high as 75 to 90%. So this is extremely important for all intensivists when you're dealing with patients. We often deal in ICU patients with abdominal compartment syndrome in the setting of pancreatitis. So it is important to quantify this mortality. If a pancreatitis or any other abdominal or subacute intestinal obstruction with manifesting as compartment, your mortality is really sitting at 80 to 90, which needs to be told to the family very clearly. And grade 3 to grade 4 intra-abdominal hypertension also, mortality is at 50 to 60%. So this is very important science to be aware of when we are trying to prognosticate these patients in ICU. So this is an interesting figure or a chart which correlates with the type of organ dysfunction that sets in with increase in the intra-abdominal pressure. So as you see, these are the intra-abdominal pressure, this is the organ dysfunction. So really the organ dysfunction starts setting in when your IAP starts touching 20 and above. So they have looked into the correlation of which are the organ dysfunction that sets in early. So the acute kidney injury tends to happen early on in the range of intra-abdominal pressure of 20 to 25. And GI dysfunction tends to occur when intra-abdominal pressure starts hitting 30. And respiratory failure and respiratory dysfunction happens when it's around 35. And cardiovascular instability, where hemodynamic instability, rising lactate, hypotension, all this sets in when it exceeds 35. So this is some sort of a rough correlation as to the organ dysfunction that sets in with commensurating with the increase in the intra-abdominal pressure. So that was one issue that we covered. So the third issue that was addressed to me was, this is very important. How does abdominal compartment syndrome affect the ventilation, the lung function? So this was the question that was discussed with Prof.Manu Malbrain. So this is very important for the trainees. Just remember this as a pictorial representation I'm showing. So these are the lungs look. So what happens? So when we ask this question, if it comes in your DRNB, it would be nice if you just put a figure because that makes our understanding very simplified. So 40 to 60% of the intra-abdominal pressure gets transmitted to the lungs through the diaphragm. So which means if you have increased intra-abdominal pressure, at least 40 to 60% of this is transmitted to your lung, and that's where your lung compromise happens because of the elevation of the diaphragm up. Because you have increased abdominal pressure, diaphragm gets elevated, and the pressure also obviously gets transmitted to the lung. And this can lead to increase in the plateau pressure. Because your diaphragm is elevated, so you have atelectasis, you have reduced functional residual capacity, then you have atelectasis, then there is pulmonary edema on the inflammatory exudates that set in, then there can be shunt fraction because some of the alveoli are not participating in the ventilation. There is perfusion, but there is no participation of ventilation. And then there can be impaired in the diffusion at the alveolar level. So these are all the changes that have shown to occur in abdominal compartment syndrome. And most importantly, you would know in abdominal compartment syndrome, there is, especially secondary to pathology like pancreatitis, there's a lot of serosities, effusions, there's increase in the dead space. There can be effusions or there can be shunt fraction, there can be VP mismatch, all this leads to increase in the dead space, and there can be impaired in the diffusion. And this leads to increase in the peak inspiratory pressure, and there is increase in the mean airway pressure. So these are all the changes that typically happens because of transmission of increased pressure in the abdomen to the lung. And this obviously affects your alveolar ventilation. So there is hypoxemia that sets in, and there is hypercapnia because of all these changes of atelectasis, increase in the dead space, shunt fraction, impaired diffusion, pulmonary edema, increase in the mean airway pressure, increase in the peak inspiratory pressure. There is hypoxemia and hypercapnia. So pictorially, if you can put it this way, I think it would make your understanding very easy also in exams. So I would think this is the easier way of remembering. So the question that we addressed was, now so many changes happen. There is a shunt fraction that increases. There is a diffusion impairment. Do we need to adopt any separate ventilatory strategy in these patients? Because we know how to ventilate ARDS patients, but in patients with abdominal compartment where 50 to 60% of IAP is transmitted to the lung, and where you would expect the P plats to be high, how do we optimize whether there have to be different ventilatory strategy? There are no major studies. If you look for studies, there's no studies to really determine what is the ideal ventilation strategy that we need to adopt in abdominal compartment syndrome. So what is largely agreed is the ArtsNet sort of a ventilation where we have subscribed to low tidal volume and optimal PEEP remains the quintessence of these ventilatory management. Having said that, there are few specific things that we need to keep in mind. So this is important. So as I said, the P plat will be high. So in ARDS, we know that we need to keep P plat less than 30. But in abdominal compartment, we cannot possibly maintain. If suppose abdominal pressure is more than say 25, 30, we cannot maintain P plat less than 30. Then we need to know what is ideal target. For that, there is this formula. For all the trainees, you can remember this. The target P plat is you have to look at mean P plat minus 7. You only have to remember 7. Minus 7 plus 0.7 into intra-abdominal pressure. So for example, if I have to maintain P plat less than 30, so we say if 30, we take mean P plat as 30. That is the target I want. Minus 7 plus 0.7. And if I take intra-abdominal pressure as 20, then 37 is acceptable P plat in the setting of ARDS with abdominal compartment syndrome or with intra-abdominal. So this is something important that we discussed during our panel, and this has come out from a study, and this is something you could keep in mind because we can tolerate higher P plat, especially in patients with abdominal compartment syndrome, and how much we can tolerate can be determined by this formula. Suppose you say, okay, would this formula work if suppose we take a normal IAP? So apply this formula for a normal IAP. So here I have taken normal IAP. So you want P plat less than 30. So you do 30 minus 7. So it comes P plat will be 30. So basically it tells that IAP is factored in and a constant of 7 is added to sort of arrive or derive a number which is considered safe for P plat as a safe P plat for ventilation. So this is something you can remember, that something we discussed. And what about driving pressure? So we all know in ARDS, the driving pressure we largely accepted to be is less than 15. Even in abdominal compartment syndrome, this is considered reasonable, but there are no studies to determine what is the safe driving pressure in intra-abdominal hypertension. So extrapolating whatever the reports and the studies, so less than 15 is considered safe even in abdominal compartment syndrome. Now the question is how much PEEP we keep. So there was a lot of discussion as to what is the ideal PEEP. The reason is how do we adopt PEEP when there is so much of intra-abdominal pressure? So there are two schools of thoughts. One is use the PEEP which equaling or which is equal to the intra-abdominal pressure or using half of intra-abdominal pressure. So there was one study which compared between the PEEP equal to intra-abdominal pressure versus half of the intra-abdominal pressure. So this study came in 2018 by the Australian group, where they looked at keeping a PEEP at 50% of IAP versus 100% of intra-abdominal pressure. So in this study, they found that 100% of IAP was very poorly tolerated because of hemodynamic instability, which is expected because if someone has an intra-abdominal pressure of 20 or 25, you keep a PEEP of 25, so it would cause lot more harm than benefit. And they compared with 50%. So if it is 24, keep 12. So with that, so this study was done in a small group of patients, 15 patients. With half of that intra-abdominal pressure, there was no improvement in oxygen. So basically it said you keep equal to IAP, it did not help. There was a lot of hemodynamic instability. 50% of IAP did not make a huge difference with improvement in the oxygen. So now what is the solution then? Gattinoni, I'm sure most of the listeners know Gattinoni. He did a small study with four different levels of PEEP, 5, 10, 15, 20 of PEEP. This is in intra-abdominal hypertension patients. And he found that high PEEP was beneficial. It improved the compliance of respiratory system. So at the PEEP of 20, there was a good improvement in the respiratory. So the summarily what we can deduce and agree upon even in our panel is PEEP has to be titrated and calibrated to the compliance of the respiratory system, which every intensive care listener would be very proficient with. So PEEP has to be titrated and calibrated to the respiratory or to the compliance of the respiratory system, so which anyway we do as a part of art strategy. So that's why the whole science of what is the PEEP that we would keep and what is the sort of a ventilation strategy that we adopt is very similar to ARDS. We agree upon low tidal volume and PEEP, which is optimized to the compliance of the lung based on how the science of the ARDS is good enough. So keeping the PEEP same as IAP does not work, and determining the PEEP based on the intra-abdominal pressure does not seem to hold much promise. I think that is the bottom line we've had. So you do the PEEP optimization based on the ARDS science that you are all aware, and titrating it to the compliance of the respiratory system is the way to go. So that is the thing we agreed upon. So how about proning? Proning in abdominal, because initially most listeners, if you recall, we would say in abdominal compartment it's hard to prone. So this science has evolved. So proning, why we wouldn't prone patients with abdominal compartment? Because our understanding was by proning your abdominal pressures tend to go up. So studies have shown that there is mild increase in intra-abdominal pressure. If your IAP is 15, by proning it may go up by 3 to 4. To circumvent that, so they have done proning can be done safely by putting chest suspenders and the hip suspenders. So they have put a pelvic suspension and the chest suspension. And this, in fact, has shown to increase the compliance of the abdominal wall and reduce the chest wall compliance. So if you are unable to prone, especially at surgical patients, abdominal compartment syndrome tends to happen in post-surgical setting, or it can happen in massive ascites where proning may not be easy with chest suspension and pelvic suspension. What they have come out with, keeping the patient supine, you can keep a 10 kg weight on the chest and with a bell suction on the abdomen. So they have tried doing this in experimental study, and this works exactly like proning. So basically keeping a weight of 10 kg on the chest reduces chest wall compliance, and by putting a bell suction like this on the abdomen, improves the abdominal wall compliance, which works very similar to the proning, and they have seen this will work. So these are some things where we need to try to do it for our abdominal compartment with the ARDS and see if all this works, because 10 kgs with saline bags have been tried in traumatic brain injury patients also. So this is something that one could adopt in a desperate situation. And studies have been done. Small sort of experimental studies have shown that this helps. So if you cannot put the weight and put an abdominal bell section to improve the abdominal. So the whole effort is to improve the abdominal wall compliance. So this is the discussion we had during our panel. Now coming to which mode of ventilation would one adopt in abdominal compartment syndrome? So there's one study for that from In et al. Studied 40 patients with abdominal compartment or intra-abdominal hypertension. They compared pressure-controlled ventilation versus pressure-regulated volume control. And they found with regards to pressure-regulated volume control was found to be superior to pressure control because it reduced CO2, reduced the mean inspiratory pressure, and reduced the extravascular lung water, and it improved pH, it improved oxygenation, it improved oxygenation index, and it improved the respiratory system compliance. So basically, there was more benefit observationally with pressure regulated volume controlled vis-a-vis pressure controlled in abdominal compartment syndrome, but there was no difference in the SOFA, MAP, or intra-abdominal pressure. So this is something we discussed. So the second last two bits that we discussed was, is there role of biomarkers in abdominal compartment syndrome? So there's, as you would agree, the clinical signs of abdominal compartment syndrome is terribly important. So the routine biomarkers that you would look from the clinical standpoint would be urine output, tachycardia, tachypnea, and lactate coming down, urine output improving. These are the typical clinical endpoints we look at, but they have studied few biomarkers. So this was one study which came from US by Ashish Khanna, where they just saw a causal correlation with high intra-abdominal pressure and raised CA 125 level with a cutoff of 35 units. So they saw that in patients with high intra-abdominal pressure, CA 125 was elevated above 35, which had a correlation. But these are all more from an academic standpoint. Possibly it doesn't make any clinical sense that we start doing CA 125 to determine if these patients have high intra-abdominal. So the clinical sort of a science in determining the pressure, looking at the trends, abdominal perfusion, they remain the gold standard. And they've even this particular study, Burnia study, this was done in 31 patients, where they looked at intestinal fatty acid binding protein as one of the marker of intra-abdominal hypertension. But these are all academic, more for experimental, and these studies were done in animals. And this was one study from Finland which looked at D-lactate level because D-lactate comes from the gut. In 10 patients, D-lactate was elevated when there was intra. This is more for theoretical academical understanding that some biomarkers go up. So just remember that CA 125 can go up, and D-lactate is easy to remember. It tends to go up. Intestinal fatty acid binding protein, and I think it's very intuitive to think because your abdominal pressure has gone, something from intestine goes up. So these are some of the biomarkers which are studied, which tend to go up, but not of clinical relevance from our practice standpoint. Just the last slide on when conservative measures fail in abdominal compartment syndrome. Like when we say conservative measures, means we monitor intra-abdominal pressure, we do the hollow viscous evacuation with Riles tube or nasogastric drainage and flatus tube to decompress the abdomen. We give prokinetics. These are all the standard measures for abdominal hypertension, where we give prokinetics, we enhance the gastric motility, we do the nasogastric drainage to decompress the stomach. Then we put the flatus tube to decompress the intestine. All this has failed. What are the options? So the option is then you have to think of surgical sort of an open abdomen. So this was a study, there was a registry study in 649 patients between 2015 to 17, and they saw this was the percentage of patients needing open abdomen or surgical decompression. Peritonitis, 51.2% needed surgical decompression. Polytrauma, 16.8 needed decompression. Hemorrhage and vascular, 11.9. Pancreatitis, as you see, very small number needed decompression. So when do we decompress? Studies have shown if intra-abdominal pressure is persistently about 25, leading to abdominal compartment, not settling with conservative, then decompression has to. When we say decompression, they put three subfacial sort of an incisions to reduce the pressure. So persistent increase of IAP more than 25 is considered one of the indication, or abdominal perfusion pressure being less than 50. This possibly is more makes more sense and maybe more pertinent from ICU perspective. Abdominal perfusion is MAP minus IAP because if it is causing hemodynamic instability, you're not able to attain good MAP and IAP is going up. It has shown to have a direct correlation with increased mortality. And maybe this may be a setting in ICU where you may be compelled to think of abdominal decompression. And this is a very good study which has shown that there is a trend, as you would agree, for most of our medical sort of a intra-abdominal hypertension like pancreatitis, seldom we think of late. We discussed a lot during our panel. We seldom think of surgical decompression. Rather, we tend to do more of uh, percutaneous drainage of fluids. Like in pancreatitis, we do pigtails. We put even up to 2 to 3 pigtails. And this is one study which has shown by doing percutaneous drainage, so if there is an improvement in reducing the intra-abdominal pressure, like if you remove 1000 ml, your expectation would be that IAP should come down by 9 millimeter mercury in first 4 hours, which means this percutaneous drainage has helped. But if this does not happen, like you do percutaneous drainage, you remove 1000 ml, and it has not helped you to reduce the intra-abdominal pressure by 9 millimeter in first 4 hours, it means that procedure has failed, then they have to go for surgical. I think this may be a good study to indicate to us in a stepwise approach where you don't jump to do surgical decompression. Rather, try all the conservative measures try percutaneous. If percutaneous has not helped you to reduce IAP by 9 millimeter in first 4 hours, then you are absolutely sure that they have to go for surgical. So this is the way science has headed. So we don't jump and go into surgical decompression. So these are some of the key specific points that we discussed during panel. For all our ICU trainees, the important aspect that we discussed quite a bit was on ventilation because there was a whole lot of non-clarity that about people trying to keep the PEEP as much as intra-abdominal pressure or half of intra-abdominal. So that there's no real science because that study really did not show any benefit. So we need to stick to our basic science as to PEEP optimization based on the compliance of the respiratory system and driving pressure less than 15. But uh, the trends are keeping towards higher PEEP in abdominal compartment syndrome. And another important lesson we learned was we can tolerate a higher P flat because most of your abdominal pressure is transmitted, and we have a formula for that which you can remember and apply in your practice. So these are some of the things that we discussed. So thank you one and all. So I request all the listeners to submit your valuable work to a Journal of Acute Care, which comes in every 3 to 4 months. So visit my website www.drpradiplangapu.com to read here. Thank you. Thank you one and all.